are critical. Are there some of these that you feel are weighted slightly higher than others, or do you perceive these 10 steps to be of equal weight?
No, that's a wonderful question, Bo. And I do think there's actually difference between all of these strategies. Now, do all of these strategies together, obviously very effective. But let's say you don't have access to one of these. You don't have air purification system. You don't have poverty-denied irrigation solution, etc. So what are you doing instead? You can definitely implement other steps to try to reduce bioburden. And we are actually in the process of using AI-based software that will allow us to determine which of those strategies are most effective. It's going to take us a year or two to come up with that answer. But in the absence of such, and I hope you'll give me the latitude to give you my personal opinion, I personally think that antibiotic administration is a very critical step. That's been shown on numerous studies to be very, very important and effective against evidence-based. And I also think host optimization is very important. I'm sure we've all seen as surgeons that we have sicker patients, they're much higher risk. So I would really take those as important steps. And the other steps, like being respectful of soft tissues, minimizing operating room traffic. I mean, these are simple strategies and effective strategies that are easy to implement, and I think they are important to administer also.
That's actually great. And I'll encourage folks here to ask questions. This is your chance to actually face-to-face virtually interact with certainly one of our global leaders. But while I'm waiting for a few of you to get the courage to ask the great one a few questions, let me continue here, Jay. If you were to think aspirationally about a future for infection prevention, what does that future look like? Where are we headed?
We're heading towards a bundle approach to this whole issue. We're learning from other fields, including computer science, for example, that how critical it is to reduce the number of particles in the room. You know, when they're designing the chips and they're putting them into like Intel or other chip makers, they have a room that has absolutely no particles. Can we get to a day where we have an operating room with no particles? Yeah, we can definitely strive to get there. We definitely need to make sure that we're making efforts to minimize this problem. I think we're moving towards innovation from other fields coming into orthopedics. We're seeing some of that really beautifully impregnate orthopedics. By other fields, I mean outside medicine even. We're also seeing a bundled approach to this problem. To do one is not as good as doing all. And I think we need to really understand that all of these modalities together are much, much more effective than just having one. You know, I'm part of a volunteer organization that sometimes is asked to go and visit hospitals to look at hospitals that have a very high infection rate. And we usually go out there and camp for a day, two, maybe sometimes a few more days, and look at everything they're doing. The hospital is expecting us to come up with a smoking gun to say, you know, your filters in the ventilation system is not working, or, you know, your surgeon has a terrible skin disease, or he has beard like me, or etc. It's not usually that. It's usually a combination of things and many corners being cut that leads to a higher incidence of infection in an institution. So for the fact that, you know, many people at this late hour at night are compromising their family time to be on this call, it shows that these are the people that care about infection. And these surgeons are going to be the ones that are very, very careful in the operating room, and they are thinking continuously about infection. So the future, to answer your question in such a long-winded way, I think we're going to borrow from other industries to make our lives better. We're going to move towards environmentally friendly instrumentations. The days of bringing 12 trays that may or not have holes in the drapes, putting them out there, and huge amount of burden in the operating room personnel and people is over. We're going to move towards better air purification system. We're going to move towards better host optimizations using better metrics. And honestly, I didn't talk about this today, but I was on the International Lip Society call earlier today, and I presented on the role of dysbiosis, microbiome manipulation, and nutritional supplementation in some of these areas. we're learning more and more about how important gut dysbiosis is, for example, in SSI. So we are going to be moving towards very, very different fields than just being stuck in the days where we were doing the same thing, but our patients were still developing infection.
You know, the thing that it rings so true. So, you know, that I've had a little bit of an interest in hip fracture management, and we've done about a decade or so of some of these trials. And, you know, when you talk to individuals, you know, when you've done the implant A, implant B, surgical technique B, and you ask sort of the experts of the world, you know, what's the future for hip fracture care? They kind of almost echo what you've just said is, the future probably isn't more implant, direct implant. It's a lot of the perioperative care. It's a lot of the stuff that happens before surgery, some of the stuff that happens after, and some of the, you know, it's a series of these, you know, tiny, what seem to be insignificant small steps that lead to the overall effect. I imagine that, you know, that is the message that you seem to be moving towards and are conveying, that it isn't going to be a magic bullet for infection, what we'd love it to be, but it looks like it's a much more bundled care approaches, which totally resonates in so many other areas as well.
Yeah, absolutely. And, you know, we can't thank you and your co-investigators and others that have contributed to that field so much. You know, we came away knowing that quick operation on these patients, early ambulation of these patients, taking care of their wounds, you know, paying attention to their nutrition, et cetera, a huge number of stuff that you've made us aware of. I agree. It is the day that we have to look at this from a different lens, because the approaches we've had haven't been as effective as we want. And why not learn from other surgical disciplines, learn from other industries, and make things better for us in the future?
So we got a few questions coming in. I'm just going to go to a Tom Wood, who looks like his hand's raised. Tom, if you're able to come on video and off of mute.
And I want to say Dr. Ernesto Guerra looks very, very handsome. And I feel that it is so late in Spain.
Okay.
I am surprised. He looks fresher than I do at this time of the night here.
Listen, Jay, I keep getting older, and Ernesto keeps getting younger. That's what I feel. Every time I see him, he keeps getting younger. Ernesto, you're next, right after Tom.
I'm jealous of his hair, and I can't believe that I can't look half as handsome as he does on the Zoom. I'm sure people are sick of seeing my pictures on the Zoom.
My wife takes a lot of care of me. Yeah, that's my advantage.
That's your secret. Good to know.
Yeah. I want to ask something. Jay, it is a great controversy still in the prevention of PJI, and it must be clarified probably with a big RCT. It is that antibiotic impregnated cement. It is practically a routine use in Europe, especially in the Northern European countries. And some literature says that only 4% of the Americans surgeons use antibiotic impregnated bone cement to prevent infection in primary arthroplasties. I remember when we were in the international consensus meeting, when this question was taken, it was not a discussion. It seems to be a battle between Europeans and American surgeons. And which is the situation actually, or which should be actually the situation, or where should we go? Regarding cement.
You know, Ernesto, that was a very, very tense and very, I would say, hot debate during the consensus. I'm going to tell you the facts to all of you on this, and I'm going to let you make the decision for yourselves. Here is the data. Everybody says the Scandinavian registry shows a reduction in infection rate when antibiotic impregnated cement is used. The Scandinavian data they're talking about is the Norwegian registry that shows the all-time failure was lower in hip replacements that were done with antibiotic impregnated cement. As far as I know, Norwegian study does not have data on the knees, and that's when we're mostly using the antibiotic-impregnated cement. The randomized prospective studies, and 3 of them done, 1 Canadian, granted, underpowered, they did not show a difference in infection rate when antibiotic-impregnated cement was used. The registry data is actually conflicting. Australian registry shows no benefit for the use of antibiotic-impregnated cement. New Zealand registry, which I just showed you, shows an increase in the incidence of infection when antibiotic-impregnated cement was used. British registry shows a reduction in the incidence of infection, including hip fractures, but British registry is really a little difficult to understand because they have 98% of people receiving antibiotic-impregnated cement and 2% not receiving it. That's really not very comparative. It is the day and age when antimicrobial resistance is on the rise, and it's been an incredibly, incredibly important problem for CDC and WHO and the rest, and us as surgeons need to exercise antibiotic stewardship. Financial burden on the healthcare is also another issue that's really important. 1 million joint replacements and knee replacements in America, 2 packs of cement per million, 2 million packs of cement with 1 gram of antibiotic. You do the math, how much antibiotic that is. So what do? I don't use antibiotic-impregnated cement. Do I have infections? Yes, very rare, very, very rare that I see infection. Do I think that's an important strategy in prevention of infection? No, I don't. But I'm leaving it to you guys to make your own decisions and determinations. I don't know why people have such a strong feeling about this antibiotic-impregnated cement. There is a little bit of the issue with the industry forcing us to use it, and industry is really sponsoring so many meetings and so many of these things to make sure that we all understand that antibiotic-impregnated cement exists. Should you use it? Maybe in high-risk groups. Should it be used in everyone? No. But again, those are the facts out there, and I'll let you all decide for yourselves.
You know, Jay, I mean, I think the thing that I would say is, and you said it already a few times, which is the preponderance of the data is observational. I mean, you know, and probably the clinical trial data is few and far between. I know there are patients that have been enrolled in trials, but it would seem to me that we need a lot more patients to understand the appropriate indications. I just have the general feeling, not as a person, as a joint surgeon, but, you know, infection is such a feared and devastating complication that there's maybe the perception, you know, and there's probably a positive bias to say, I'll try anything I can at the hope that it may, you know, prevent infection. Even if I'm not fully convinced that, you know, it has a strong efficacy, but it may. I mean, I could say that could be one of the issues there at hand. Tom, did you want to now go ahead and ask your question? Tom Wood.
Yes, thanks a lot, Jay. I'm actually on the bike, so I'm going to leave the video off. But along the lines of antibiotic stewardship, what about the emerging evidence for topical Danko?
Yeah. Great question, Tom, and well done that you're exercising, and it's just true multitasking. Don't tell my wife, though, that you are on the bike and listening to a Zoom, because that's what she's going to ask me to do from now on. But great question. The CDC recommends against the use of topical antibiotics, against the use of antibiotic ointments and dressings impregnated with antibiotics, etc. Why? One, there's no evidence. Every piece of paper you read is retrospective with no control arm, majority coming from spine literature. So randomized prospective study, and that needs to be done. And to your point, Tom, we have to be very, very mindful of AMR, antimicrobial resistance. Pouring vancomycin powder into a wound is not going to protect the patient from developing infection, or at least not without the proper evidence. So again, as Mo put it beautifully, majority of these are observational studies without the proper design. If we really feel strongly about the use of vancomycin powder, we should definitely be doing a randomized prospective study. Now, the NYU group published a paper, randomized prospective study, and they did show that the use of vancomycin powder plus povidone iodine was more effective in prevention of SSI than normal saline. But what we couldn't really dissect out on that, was it the vancomycin, was it the povidone iodine, or was it the combination of both? So they are in the middle of randomized prospective study called VIP study. being led by Rand Schwarzkopf, and hopefully we will have that data soon. They're having 4 arms, which includes separating the vancomycin arm from povidone-iodine. So until that data emerges, I don't pour vancomycin powder into a wound. Thank you for that great question.
That's great. Joseph.
Yeah, thank you for the great talk. It's been very interesting so far. So my question is a little more, I guess, philosophical in nature and gets at the heart of evidence-based medicine, because bacteria seem to have like almost a unique challenge in that they are always changing. There's like an incredible amount of diversity and it's dynamic. And so my question is, to what extent does research conducted 5 years ago simply is just wrong in today's age? And like, at what point do you have to discount gold standard randomized control trials or redo them and update them and, you know, recognize that maybe bacteria in Norway or I'm sorry, I'm forgetting the countries, just might be different than the bacteria in the United States based on diversity?
That's a fantastic question, Joseph. Again, if you look at the organism profile causing SSI, both the European CDC and the American CDC, the profile has definitely changed. We're seeing more of the resistant organisms. We're actually seeing very uncommon organisms causing PJI. You know, in the old days, it wasn't rare. Somebody would stand on the podium and say 80% of PJI is caused by gram-positive organisms, and then majority are staph. That may have been true 20 years ago. It isn't true today. Gram-negatives are on the rise. Fungal infections are on the rise. So yeah, there is a lot of changes. So to your point, a study in which, you know, we administered cefazolin in a randomized prospective study may need to be repeated because the organism profile we deal with today in the society is different than what we had. Medicine is an emerging science. It's a fluid science. The beauty of medicine is that we continue to discover more. As we discover more, we learn that we know little. And as you know, that sort of continuously engaged. As doctors and surgeons, we're very, very inquisitive in mind. We always want to do the right thing for our patients. And in the process, we really owe it to our patients to try to either generate the evidence or at least know that there are limitations to the publications that are published.
And that was a great question. Thanks, Joseph. There is a comment and a question in our chat for you, Jay. It says from Edward Jaffe, would you consider changing exterior gloves after draping and before applying Ioban? It's quicker than repeat skin prep and waiting 3 minutes to dry.
Yeah, so great question, Edward. Yeah, I actually do use three sets of gloves. And after draping, I take out the outer glove. So we really have triple glove. Great strategy. I agree, that's fantastic. And here is another thing I'm going to tell you, but I never admit to the 3M guys. I never wait for 3 minutes. I apply it and then I wipe it out and put the Ioban. I can't wait for 3 minutes. That's 10% of a knee replacement time. So you're right. It is a little annoying that you have to wait 3 minutes, but I'll never admit to 3M that that's what I do.
Listen, you know what? I see a few people here that I recognize on video, and maybe I shouldn't call them out, but I think they're learned individuals who probably have a few comments. I wonder, Tom or Jim Powell, Thomas Bertoya, if you have any thoughts or comments about what you've been hearing this evening.
Hi, Mo. Thanks for asking me to get online here. Hi, Jay. Great presentation as always. I do have a question about the use of vac dressings. I've started to routinely use it in revisions, and I'm finding it helpful. And I just wanted to get your thoughts on the role for vac dressings at the end of surgical procedures.
Sure, Jim. Great to see you. And I see that you're using your bike as well, but in the background only. That looks great. So I use VAC in the following circumstances. And again, there's actually quite a bit of randomized prospective studies done on this. I did a meta-analysis with the KCI group a while ago, and Carlos Aguirre, John Cooper, and a couple of other guys have done a beautiful job of randomized prospective studies to show that there's definitely a role for the use of VAC in high-risk patients. And I'll be interested to see if, Jim, you agree with me. But the high-risk patients I define are those that have had multiple prior operations, patients with really precarious soft tissues, patients undergoing revision for infection, patients on anticoagulation who are going to go back on their anticoagulation and bleed for a while, patients undergoing megaprosthesis reconstruction when there's sort of dead space that might collect and cause issues, and then obese, especially like periprosthetic fracture fixation or non-elective emergency surgeries. And finally, in patients that are on steroids or immune modulating agents with really, really bad skin who may have difficulty healing. And then you could add the smokers, but in elective arthroplasty, we're not doing this on heavy smokers. But those are my group of people that I would routinely put a vac on for 2 days and then take it up before they go home. What are your thoughts, Jim? And I'm going to charge my computer and I'm listening.
Yeah, I must admit I haven't been using it in any primary situations, although probably I should in some of those high-risk patients that you've just listed. I pretty much limited it to the revision patients, but again, it's the high-risk revision patients of late that I've been putting it on. Anybody that's previously been infected, the significantly multiply operated patients with poor soft tissues for sure.
Yeah, it seems to me though, when you look at areas where you've got randomized trials, I think it does behoove us to take a little closer look at that data set to both your points. And it does look like there is an effect that's worth considering. So, yeah. Tom, did you have any comments, any thoughts? I know you've been listening away here. You're on video, and feel free not to comment, but I thought you might have a thought or two. You're a thoughtful guy.
Well, that was a terrific presentation, and I think I'm doing about 8 of 10 things, so I'm sort of on track. But I've heard you speak a few times, so every time you speak, I add another something to my regimen. I do the 3 glove thing as well, and then dispose of the third set after the drapes run, but before the eye event. I remember reading some article years ago where they were randomly culturing glove tips every 20 minutes and different time intervals, but as frequently as every 20 minutes, you'd be getting positive cultures off of glove tips. And this was a few years back. So that certainly informed my practice to change my gloves frequently. And so I won't touch an implant that I don't have fresh gloves. So for a hip, then it's new gloves when the cup goes in, new gloves when the stem goes in. And no one in the team is allowed to touch the implants other than me. So I think that's important because they're certainly things get contaminated just as time passes. And the other comment is I have a pretty low threshold for putting a Prevena on. We put the Aquacel on in the OR. We use the silver impregnated. Whether that makes a difference or not, I don't know. It certainly costs a bit more, but and then we leave that on until it's time for staples to be removed. So I know the product insert says 7 days, but really we leave the Aquacel on for 12 to 15 days, and they just work fine. But certainly if it fills up and needs to be changed, then I go straight to Prevena at that point. Anyone who's got any sort of drainage, and Prevena really works terrific. And I find that it just cuts down the whole edema around the wound, and particularly in the obese and the diabetics. But I think that was the only comments I would make.
Appreciate it. Thanks so much. We are approaching the end, and the end is always sad when it's a discussion with Jay Parvizi. But Jay, I wonder, and I know I'm going to be opening up a can of worms in the last few minutes here, but while the hope would be, just as it was for many of our cardiology colleagues, to say that it'll be the end of mortality after myocardial infarction, or the end of serious impairment after stroke for some of our neurologists, when you think about the possibility of the end of infection, the reality is that until such time, we will still have to deal with infected patients. I presume that the same care of dealing with a patient who comes in with an infection, you have another 10 steps or another set of goals. I'm not asking you to share them, but if people want to get more insight or more information around the management of infection, where would they go?
Yeah, absolutely. I think the first would be to go to the international consensus document. There's huge amount of really important information coming from 900 experts around the world, not just one person, but a collective wisdom is there. And then the second is that there are actually some sources of videos and blogs and other things that we continue to do to try to improve the management of these patients. And I'm happy to direct you to those sites to be able to access those material. But I would say just download that app. There's a lot about management of patients with all the questions that you may have in your mind. All those answers are there with some of the supportive and evidence.
And as my final question to you before we adjourn for this evening, when you think about the remaining questions, and we've talked about, the possibility of answering these questions with randomized trials, why don't we have bigger trials? Like, why are we now just getting into the trials where you're getting into the appropriate power? What's been the barrier to conducting what would be, and like with the number of cases, the number of patients that are seen and operated on, why haven't we had the 15, 20,000 patient trials similar to the cardiology area? And what's changing, I guess, culturally towards getting to that goal?
You are the best person to answer this question, Mo. You've conducted a very, very large scale trials. You have this unique and incredible ability to bring different surgeons and different institutions together to conduct them. Obviously the challenges that exist. Randomization of patients are hard. The larger trials are difficult from both cost and time perspectives. But really, there is no excuse. Honestly, no excuse. You and I think we looked into this antibiotic impregnated cement issue a few years back. We just couldn't find a funding source. We thought that it was going to be around 6,000 to 7,000 patients. So I do think that with more and more of attention being paid to the issue of infection, more of these clinical trials will be done. You see, people didn't really admit that infection was a problem. And I think the fact that we've come to realize it is a problem, and perhaps it's moved to number one or number two to be a problem because we've solved all the other issues. Osteolysis is gone, and osseointegration, aseptic loosening, all of that stuff, wear, etc., is now not a problem for us in joint arthroplasty, and infection has become a major issue. So I do think, one, we're paying more attention. Two, maybe we're seeing more infections than we used to see before. And I think, the question of resistance and the changing organism profile, et cetera, has brought our attention to it. So we will be seeing more of these randomized prospective studies. And many are happening right now as we speak. In fact, there's so many of these randomized prospective studies that we don't even know which of these trials to randomize our patients to at the moment here at Rothman. Well,
there you go. I mean, that's not a bad problem to have. And the thing I would say is, in the cardiology world, and I use that analogy only because, the outcome was fairly rare. And so, but they took it very seriously. They took a 2% risk of mortality and took it to well under a percent with real investment. The other thing was industry partnership, in our field has been, considered, well, they know that's conflict. But the truth of the matter is, it is through critical industry partnership that ultimately leads to these large trials getting done. And at the end of the day, it's in all of our interests to help solve that problem. In cardiology, some of the biggest studies have been done, and it couldn't have been done by the NIH and could not have been done by plain. There's not enough money in the system to do those trials. So in many ways, I do think it's going to have to be a multi-tier, multi-stakeholder solution. I can't thank you enough, though, Jay, for spending time with us, providing insight. Thanks to all of our those who have stayed along and provided your insights. Appreciate that. Certainly, again, this is part of the 3M infection prevention series. So thank you again to our partners at 3M for this particular series in the OE World Tour for helping us bring these sorts of events to light. So everybody have a wonderful evening. Jay, once again, thank you so much.